This is Cancer of the Breast Awareness Month. And the reason for that is that cancer of the breast is a major problem in the world, but especially in industrialized countries or first world countries where is the #1 cause of death in women in America, in just about all of Europe, Australia. And it is not, fortunately, in underdeveloped countries where other malignancies are more prominent, like in Mexico, for instance, cervical cancer is more of a problem in women than breast cancer. But fortunately, over the years and due to a tremendous amount of research and funding for that research, the survival rates of women have improved in the last decade. Some of it is a little bit obscured because due to screening programs, very effective screening programs, the breast cancer patients come earlier to treatment, and so it is believed that that's one of the reasons why women are living longer. And some of the critics would say that they're not living more, that they're being followed longer because they were found earlier. But at any rate, cancer of the breast has improved tremendously in the last couple of decades, especially in the form of surgical procedures. When I started my surgical career, radical mastectomies were done, and that was already an improvement. A radical mastectomy is where the whole breast tissue was removed. The muscles of the chest of that side were removed, and all of the lymph nodes were cleared out. Between 80 and 100 lymph nodes would be removed, and then all of the women would have issues with strength, lack of strength in their arm, the side that was affected, and all of them would develop lymphedema. And thank God that has changed dramatically, where now radical mastectomy is virtually the treatment of choice, where only a few lymph nodes are removed and no muscles are removed. Before that, the super radical mastectomy, virtually a fourth of the body was removed, and thank God that's not true anymore. The hormone therapies have improved tremendously. Now we have many more options to treat women with hormone-dependent tumors, and radiation has reduced significantly in the treatment of breast cancer, whereas now targeted therapies are coming more into play, and I think that's for the benefit of women. Regardless of that, the 5-year survival rate for stage 4 breast carcinoma ranges between 20 and 30%, depending on the studies. Overall, around 30%. And that means that 70% of women will not survive 5 years when they have stage 4 cancer. And in our experience and with our treatment, stage 4 breast cancer patients that come to us after being really sent home to die, 50% have 5-year survival chance. And when a patient comes to us virgin to treatment, 75% of the women will arrive at 5 years. And we believe very strongly that the reason for that is our integrative approach, and not so aggressive therapies are given to women. So we're very proud of that, and that's one of the tumors where our responses are the best. And right now, for instance, last week we saw a number of patients that came for the second or third or fourth time with extremely good results, very encouraging results. So we're very happy and thankful to God for those results. Dr. Larraga has been with us now for a good number of years. So she's very experienced now in our protocol, and I would like to know if you want to add anything to that.
Yes, actually, I want to add that, well, surgery has really changed in a few years, but I remember that when I arrived at Oasis, that you always try to just remove the lymph nodes that were affected. Of course, on curative surgeries, but also to try to diminish the affectance to lymph nodes. And nowadays, we know how important lymph nodes are to the lymphocytes, and how we know that indeed cancer can affect lymph nodes, but our lymph nodes contain all the immune cells that can fight back. So I think that is lovely to know that you always care when you are in the surgical room. And just when I heard that you say to the patient, like, we remove just the ones that were affected, that's amazing, because they the patients have good quality of life, they don't have all the side effects, but also we're taking care of the immune system. So
Correct, and that's so important. She's right. Most of the cancer-fighting cells arise from the lymph nodes, and that's actually where they're activated, and that's why it's so important to maintain as many healthy lymph nodes as possible. And so that's another big change from our side in comparison to many other oncological centers. Another big difference that I believe is happening here at the Oasis is that we take into account the emotional and spiritual needs of our patients, not just the physical needs. And obviously, the physical needs are very important, and so therapies that will fight the tumor are very important. But it is also important to exploit, in the good sense of the word, the capacity that our body has to fend for itself and to fight cancer. And so immune therapies are a big part of our therapy, and they will range from meditation, laughter, singing, all the way to very specialized vaccines that are very specific or personalized for the patient. So immunotherapy is a big entity in our therapy, and I'm very happy also to convey to you that more and more conventional immunotherapies are coming about for the benefit of patients. And so that finally, after many years, the conventional and orthodox research groups are coming to terms with the fact that we need to work for the immune system and not just against the tumor. And unfortunately, many of the therapies that we use against the tumor are very immune suppressive.
Yeah.
All chemotherapy is immune suppressive, surgery is immune suppressive, radiation therapy is immune suppressive. So definitely patients need a tremendous amount of help as far as the immune system is concerned. So I think that Dr. Larraga and I would be ready for questions. And I know that a number of you have submitted questions, and we'll be happy to address them. And obviously, we'll also take care of a number of live questions if you have them.
Perfect. We're gonna, please, we invite you to write down your questions on the chat or the Q&A box. Any questions you might have about our treatments, about your specific case, Dr. Contreras or Dr. Larraga will be happy to answer them. We have around 100 pre-submitted questions, so while you get started asking your live questions, we're gonna start off with a pre-submitted question from Leanne Christensen. Her question is, how to get diagnosed without biopsy that can cause, how to get diagnosed without biopsy that can cause the cancer to spread. I imagine she's saying how to get diagnosed without doing a biopsy so that cancer will spread.
Nowadays, I think there will be a possibility in the near future where we may be able to diagnose cancers without biopsies. It's called the liquid biopsy. It's still in infancy, not very reliable. And so for the time being, there is no way for us to understand a patient's cancer without a biopsy. And tumors are not just malignant. Tumors have many variations to them. For instance, cancer of the breast is not just one cancer. It's a family of tumors. And depending on the surname, cancer of the breast, that is ductal, cancer of the breast, that is lobular, cancer of the breast that's hormone dependent or not, cancer of the breast that is triple negative, and so on and so forth, will be treated differently depending on the diagnosis. So for the time being, we cannot avoid a biopsy. And fortunately, the possibility of increasing the risk of spread due to a biopsy is extremely low, whereas the benefits of knowing what type of tumor and how aggressive it is override the risks by far. So for the time being, we still have to do biopsies in order to offer the patients the best treatment possible.
Perfect, perfect. Dr. Larraga, any color commentary? you would
Yeah,
like to ask?
I think that probably the part of the widespread comes to the inflammation process that comes along with the biopsy. But fortunately nowadays we know protocols that can control inflammatory process and can diminish the sensation that patients feel after biopsies. And indeed, probably maybe 10 years from now, that the proteome therapeutics we can catch up with circulating tumor cells and all the liquid biopsy. But nowadays, the biopsy is still our best option to understand the behavior and the genetics of the tumor.
Perfect, perfect. Another pre-submitted question from Leanne Christensen. For breast cancer treatments, do you use Rife frequencies? I know we don't, but it's a good question.
It's an excellent question.
Yeah.
I am convinced that the future and the solution of cancer is in frequencies, because every cell, every element in the world in creation has a very specific resonance. And so Dr. Rife somehow found the way to affect specifically cancer cells without affecting any other cell, and would kill the malignant cells without damage to normal tissues. And he was able to cure a good number of patients in the early 1900s. Unfortunately, most of his research was lost. And to date, we've tried here maybe 20 different Rife machines.
Yes.
And every time somebody tells me that they have a Rife machine, I will try it because I'm convinced that that is the solution. Unfortunately, to date, we have not received any machine that was able to, or that has been able to really reduce the size of tumors at all. And I'm very sad about that. But if anybody out there has a new machine and wants to bring it to us, I will gladly do a trial because I'm convinced that that is going to be the answer. Unfortunately, to date, we haven't found any.
I've tested Rife machines with you.
Yes.
We've got a bunch, and the codes and everything. It's tricky, but yeah, we're praying that a Rife machine comes along because we do believe that frequencies is part of the future of cancer treatment.
Yes.
Let's go with a live question. We'll go back and forth. Gail, you're the first question. Is breast cancer the cause of death or the treatment that are being given for breast cancer? Great question. Great question. Yes.
Unfortunately, I believe that we as doctors sometimes contribute tremendously to patients failing or patients not surviving. And it's true that in many cases the therapy is worse than the disease, and that is why my father 60 years ago started looking into alternatives, because the results have been so dire. And now 70 some years after the war on cancer was declared in America, and billions of dollars have been spent in research, and bright minds are working on it, we have very little to brag about. The way to determine whether something in medicine is really helping or not is what is called when you measure absolute death. And unfortunately, every year in America, more people are dying of cancer than last year. That is the absolute death. So by that measure, we're failing. That people are living longer, it's true. That some of the therapies are less aggressive is true, and I think that's going to improve. But yes, it can be that in many cases, the therapy can be worse than the disease. In the first book that I wrote, shared with the audience that doctors can be threatening. And one of the things that hurt me the most is that I found that every time doctors go on strike, the death rate drops significantly. So that's not a good, a good thing for us.
Yeah.
So I understand your question, and believe me, more and more doctors are striving to abide by philosophies like ours, where our treatment, our philosophy is based on two pillars: do no harm, that was stated by first, do no harm by Hippocrates, the father of medicine, and Jesus said, love your neighbor as you love yourself, love your patient as you love yourself. And if you treat your patients with those philosophical pillars in mind, your chances of harming the patients are going to be much less. But I understand your question and concern, and believe me, I think that we're not the only ones trying not to kill patients. I read a really nice booklet many years ago. I was walking on Fifth Street in Manhattan, and when there were still bookstores, now they don't exist anymore. I'm dating myself. So I'm walking and I see this booklet that says how to be a good doctor in 17 tips on how to be a good doctor. So I bought it immediately. Tip
That's
number
amazing.
1, kill as few as you can. So I understand your question, and believe me, not just us, but many of us are trying to be better healthcare providers.
That's great. That's great. That was a great question. That was a great question. Let's go with another live question we're getting. And Gail, praise God, do no harm and love one another. Thank you, Gail. I appreciate that. Why don't we go with Lisa? Can you please talk about the correlation between being overweight and recurrence? Great question.
Well, first, overweight patients have a higher possibility of developing cancer and many other diseases. I don't recall reading any article that would state that being overweight gives you a higher possibility of a recurrence, meaning that you were treated either surgically or in any other way. The patient went into what is called a complete remission, or what was called a complete remission, or nowadays we say no evidence of disease. So I know of a number of studies that show that the incidence of primary tumors is much higher in overweight persons, especially obese. But I have not read anything about recurrences. But it stands to reason to believe that if you increase your chances of developing cancer in the first place, that the possibility of recurrence would be higher if you are overweight. Have you heard anything about that?
Yeah, but it's just in ER positive cancers where,
True.
yeah, because the fat tissue increases the estrogen receptors and the estrogen production. Mhm.
Yeah, that would make a lot more sense. Other than that, I haven't heard anything.
Perfect, perfect. Great question. We're gonna go with a pre-submitted question from Millie Barr from Oxford, UK. That must be, you will be very smart.
And
so
the
close to that.
like
So close to the university. And we actually get a lot of patients, unfortunately, with triple negative breast cancer.
Yes.
And more, we see more of it as the years gone by. Can you talk a little bit about triple negative breast cancer as a very common diagnosis?
Unfortunately, two things are happening in the last decade. Cancers are being more aggressive, and they are appearing at much younger years. And triple negative is one of those that used to be extremely rare. And now I would say probably around 25 to 30% of our patients are triple negative. And triple negative is associated with a poor prognosis. They tend to be a lot more aggressive, and they tend to respond less to treatment. Fortunately, even in triple negative cancer stage 4, our results have been very, very encouraging, in spite of the fact that they're more aggressive. And the younger the woman is, well, there's also breast cancer in men, not as common. The younger the person, the higher the aggressivity of the malignancy. But again, we're very blessed to have as good results in triple negative breast cancers as in triple positive, which would be the counter as far as prognosis is concerned. But yes, it's happening more often and in younger patients.
Yes, 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 yes.
I'm hoping
Okay.
that she's awake to see the answer because she's from UK, right? So
Yes, yeah.
probably she's
Yes.
sleeping.
Either which way, all this is recorded. It'll be on our YouTube page tomorrow, our Facebook page tomorrow. We'll have snippets and everything about this. So why don't we go with another pre-submitted question and see what we got here. Let me see, breast cancer. Okay, so Javier Romero is asking, is the age at which one develops cancer a determining factor in whether the cancer was hereditary or caused by lifestyle, or are all types of cancers hereditary? So two-part question. Is it lifestyle or genes?
Nurture or nature?
Nature, nurture, yes.
Well, cancer is not hereditary. We're always talking about if your aunt and if your mother and if your sister and all of those things. But cancer is not hereditary. I'll just give you an example. In China, only one person in a 100,000 population will develop cancer of the breast. In America, it's 150. 150 times higher, the incidence. And so you would say, well, then the Americans have the gene, the bad gene, and the Chinese don't.
That's about the China study, right?
Yeah.
Yeah.
The China study, yeah.
Unfortunately, when Chinese women, when they're young and they come to America and they adopt rather the American way of the lifestyle, especially the eating habits, they will have the same incidence of breast cancer than Americans rather than the Chinese, even though they're Chinese.
Is it one generation apart or
It can be, no. We're talking about the person. If they come as children
children? Okay.
to America, if they come as adults, especially middle age or more, they will keep that protection. It's amazing. So lifestyle has a lot more to do than genes. Okay. Now, cancer is a genetic disease, but it's not the same as being hereditary.
Okay.
So what we're inheriting then is habits, bad habits, and bad recipes.
Yeah.
And so that's the reason for it. It's not genetic. There's only 2 cancers that are genetic per se, that are hereditary. Colitis ulcerativa. Ulcerative colitis. That for sure. All patients with that will end up having a malignancy. No, it's not ulcerative colitis.
Leukemia, the Philadelphia.
And
yeah,
yes,
gene.
it's not ulcerative colitis. It's colitis. Well, it's a form of colitis where the whole colon
The Crohn's?
fills up with, no, that's Crohn's disease. It'll come to me. But those are truly genetic
Yeah, they have the
traits
gene. Yeah.
that you inherit, okay? But breast cancer is not one of them. Lung cancer is not one of them.
The BRCA BRCA?
No.
Okay.
So BRCA gene. Now, the BRCA gene you can inherit, but not all patients that have the BRCA gene will develop cancer. Okay, so you just have a much higher possibility of developing cancer. So if you have BRCA 1 and 2, your chances of developing breast cancer is about 86%, whereas the normal population that does not have that gene, they have about 13%.
Okay.
And it also increases tremendously the possibility of you developing cancer of the ovary. But it does not mean that you have to.
What about, I see sometimes that women do a radical mastectomy kind of to prevent them having what do you?
That's the bad part of this. There are studies that show that, women that have the gene in order to protect themselves from the BRCA gene. They will do a double mastectomy, prophylactic, it's called, and also prophylactic oophorectomies. But what if you have other genes? Well, what else are you going to be removing?
Yeah.
And it does not mean that for sure you will not develop. Okay? So I feel that prophylactic mastectomies in young women is criminal. It should not be done. And so relatively, these procedures lower the risk, but in absolute terms, it does not at all. So what is relative? Again, relative is percentage-wise, but in the absolute number, it does not bring much benefit. So I do not agree with prophylactic mastectomies for breast cancer, especially when there are studies that show that if women that have the BRCA genes improve their lifestyle, they will lower the risk of developing breast cancer, pretty much like any other woman would. So I would not propose.
Any radical mastectomy and lifestyle versus.
And that's what we
versus-
call epigenetics. That
Correct.
is the lifestyle.
Epigenetics.
Yes.
Got it. All right, let's go with see, we just did a live question. Let's go with a pre-submitted question from Merle Kember from Prince Albert, Canada.
Before we go into that, I usually don't go into epigenetics because it's a little bit more complicated, than just saying lifestyle. But I would like you to explain to our public what we mean by epigenetics. This is a very, very interesting and important. It's not a concept anymore. It's not a theory. It's a fact.
It's a fact, yeah. So, like Dr. Contreras said, genetics and hereditary is two things. We do have genes that can be like stress, for example, with age, every time the cell divide. However, we have a lot of external factors that can cause stress to the cells and can happen these mutations. So basically the cell will stress and modify to survive. And this is when we can have all these mutations that can lead to cancer. So epigenetics is basically all these external factors that can induce this stress in the cell. And like Doctor said, it's not only lifestyle, but like nutrition is a big thing, the emotional, because when we talk, and that's why we take into consideration a lot the emotional and the spiritual part, because every time that we feel under chronic stress, that we are depressed for a chronic time, we release certain hormones that can cause stress to the cell. So indeed, it's not a theory, like Doctor said, it's something that is going on in our body, but maybe we just get used to it and we don't feel it, and our cortisol is like super elevated all the time, and our cells tend to change until it's a chronic change. It's not the same. So this is the epigenetic, all the external factors that can induce to a change in the cell and can induce to cancer. So indeed, it can be the nutrition, can be the environment, can be our hormones, can be all the hormones that are released in our brain. So yes, it's a very complex scenario.
That's a very good explanation. So genetic is when the change starts in the DNA itself and you have a mutation. Epigenetic is anything around the DNA that can affect the DNA to make a mutation. And so that's why our environment plays a major role in the development of cancer. But other epigenetic factors can be emotional and even spiritual.
Yeah, for sure.
That's amazing.
Medications.
Yeah.
Stress.
Yes.
Yes.
Stress. Yeah, for sure.
Everybody stress, diet, lifestyle,
Yes.
exercise.
Yeah.
Yes, let's take it easy. Let's enjoy life. Let's go with a live question here. 1 second. Let's see. Okay. Trisha, anyway, you can turn up the volume. I'll try to do that right now. Let's see. Questions here. Is using a cyberknife, is Oasis using cyberknife for breast surgery?
No, And I don't know that many hospitals are using CyberKnife for breast surgery. CyberKnife is very well accepted for brain tumors. And the difference between CyberKnife and radiation, CyberKnife is radiation that will be guided very specifically to a tumor rather than, for instance, whole brain radiation. There are other methods that are being used for the breast for ablation. So radio frequency is one. The other one would be cryoablation, and the other one is just with heat, with extreme heat. And they are very effective, but not many are already approved, especially for breast cancer. Why? Because lumpectomies to date have proven to be very effective, and the possibility of recurrence is low. There are no studies that show that ablation or the removal of the tumor through CyberKnife or any other means is as effective as a lumpectomy. I think those studies will come in time, but for the moment, no, we're not using it, and I don't know of many institutes or institutions that are using CyberKnife for breast cancer tumors.
Okay, okay. I just want to take a moment and say that if anybody is interested in talking to one of our doctors about treatment here at Oasis of Hope or about anything that relates to your cancer diagnosis, please feel free to call us at 619-690-8450. That's 619-690-8450, or our 800 number, toll free, 888-500-HOPE, 888-500-4673, or go on our website. So wealth of information.
Me
And
pasas un libro.
I think Dr. Contreras is going to give a book giveaway.
Well, a lot of the information that we're talking about is in my latest book, The Art and Science of Undermining Cancer. I think this would be very informative to you if you have cancer, and it would be very good for you if you do not have cancer, because we present here all the factors that you can apply to your life to reduce the possibility of developing cancer. But patients will be benefited tremendously with this book, because you will get information, sufficient information to make an informed decision of what you want to do with your malignancy. And we can offer a few books.
Yeah, so we'll do an email to about 10 lucky participants of today and receive a signed copy of Dr. Contreras' new book. But also, if you do not want to wait, you can go on our website and you can download a free ebook of Undermining Cancer. So there's two ways of getting them. So thank you. I appreciate that. We're going to go with a pre-submitted question. Can metastatic breast cancer to the bones be reversed without conventional medicine? Very specific.
Oh, yes. I don't know if we have a couple of cases here where we have patients with massive metastasis to the bones from breast cancer that can completely disappear with alternative therapies like ours. So yes, it is possible. And our treatment has proven to be very effective in advanced breast cancer with metastasis to the bones, not only to the bones, to the liver, to the lungs. So yes, even if you're in stage 4, you can undergo treatment and have no evidence of disease after a few months of treatment.
Perfect. We actually have the cases here. If you want to.
Well,
yeah.
we can probably
We
show.
can do it at the
yeah, a little bit later when.
Perfect. Let me see. Some questions here. Okay, so Anna is asking, can you recommend an alternative to kill hormonal plus stem cells for those who may not be able to afford treatment?
Okay, yes, there are a number of anti-hormone treatments available for patients with hormone-dependent tumors. You only can get them through a prescription, and those medications are only prescribed by oncologists. there are no natural treatments for the blockage, the complete blockage of hormone production in your body. They do not exist because it's not a natural thing. You will find supplements that can balance your hormone production and help you improve your quality of life, but there are no natural elements that can block the estrogen production. Now, as far as stem cells from cancer, there is sufficient evidence that metformin, a drug used widely around the world for diabetes type 2 patients, it has proven to kill stem cells from cancer, and that's a part of our therapy in all of our patients to reduce the risk of recurrence.
Perfect, perfect. And let me see another live question. These are really good. How do you feel about RGCC testing?
We did that for a long while, many years ago. And unfortunately, we did not find a good correlation between the recommendations of the test and the outcomes. And sometimes exactly the opposite of what was recommended was the therapy that really worked for the patient.
It's like
They're-
a Greek test?
Yes.
Okay.
So they're expensive, and for that reason, because the reliability is not high, we decided to stop using it. We did use it for a while. I hope that, with time it will improve. The only test that I've heard that is really that you can rely on is a test that I'm not sure if it's still being done in Israel, in Jerusalem, where they take tumor cells from a patient. They implant the tumor in about 10 mice, depending on the type of tumor and the diagnosis. And then they treat the 10 mice. And the treatment is the best, is the one that they actually give to the patients.
That makes
They are
sense.
still
That
doing
makes sense.
And it's the only one that really makes sense to me. Unfortunately, it takes about 6 months to determine that,
Yeah.
and many patients cannot wait that long. And so that's why I didn't know that they were continuing to do it, because it's so impractical.
Yeah.
But other tests have not proven to be that reliable. And so it's more the experience and the art of medicine that will help you determine how to begin and then to adjust the therapy depending on results, which is what we do here at the Oasis.
That's great. That's great. Can we talk about a little bit about immunotherapy? I mean, I know that this is like the big. I've seen amazing results with the new immunotherapy. We have an immunotherapy lab here at Oasis of Hope, and we're developing these cancer vaccines. And I wanted to give the floor to Dr. Contreras and Dr. Paulina, talk about the what's new about it, what's coming out, what results have you seen about the dendritic cell vaccines and the lymphocyte vaccines and everything that's going on right now with the immunotherapy lab.
Okay, so at the Oasis of Hope, we have this two-tier approach to cancer. One is the metabolic entity of cancer. So we know that cancer is a genetic disease, correct? It's caused by mutations. But there are so many mutations. And in order to treat cancer effectively, when these targeted therapies, so targeted therapies are developed for the treatment of the proteins that are produced by these mutated cells that are beneficial to the tumor. And so when you can target that mutation, you can target that protein, and then that protein is not going to be produced, and the cancer is going to suffer. That's why they're called targeted. You target just one mutation. Now, the average mutations of a breast cancer patient, for instance, is about 75. So we will not have the cure for cancer of the breast until we have the 75 elements. And for each patient, so one patient may have 75 different than the other. So it's a daunting problem. And not only that, it's going to be terribly expensive, because to date, the cost is around $10,000 per targeted therapy. So imagine that you need 100 every 3 weeks. So you would be spending $1 million every 3 weeks. And
Considering that it's a nanotechnology, all the side effects from each targeted
and
therapy,
each
right?
one of them has, yeah, so compounding that, it's not going to be possible.
Yeah.
Compounding the side effects, that's.
But all of these mutations have what is called a metabolic impact on the patient. And those metabolic common denominating factors are few. So because of the activity of cancer, cancer is a tissue that protects itself from oxygen. So all malignant tumors are hypoxic.
Mhm.
That is a metabolic fact. Okay, it doesn't matter if it's cancer of the colon or the breast or the pancreas; they are all hypoxic. Because they are hypoxic, they cannot metabolize carbohydrates effectively. And so, for instance, in a normal tissue, the normal tissue, for every 1 unit of carbohydrates, the cells will produce 32 units of energy.
Okay.
A cancer cell, because it metabolizes it without oxygen, it obtains only 2 units of energy instead of 32.
Yeah, it requires a lot of effort.
And so it requires a lot of sugar.
Yeah.
That's why people say cancers love sugar.
Mm.
They don't necessarily love it. They absolutely need it because they grow so fast in comparison to other tissues that they require a lot of sugar. And this is the basis for the invention of the PET scan.
Mhm.
Mhm.
What is a PET scan? A PET scan, they inject into you sugar tagged with a radioactive material because the tumors need so much sugar,
And then
they
start.
uptake it and they light up. So I call it radiation for dummies. Anybody can read it, right? The tumor just lights up. Because they cannot metabolize the sugar correctly, then they produce lactic acid in a very high amount in comparison to other tissue. So all tumors are acidic. And there's about 10 different things that, regardless of what type of tumor you have, those metabolic are the same. And so we've created a therapy that addresses precisely those. Ozone to increase the amount of oxygen, the diet to reduce the amount of sugar. I'm just giving very broad spectrum things. Baking soda that reduces the pH, that increases the pH specifically in tumor tissues, and so on and so forth. And so that's going to be a therapy that it's the same for everybody else. And then on the other side, we have an ultra personalized therapy for our patients. What is that? That's the immune therapy, where we create within the immune system of the patient an anti-tumor task force specifically for that patient and specifically for that tumor. And so this combination of an extremely personalized therapy and a common denominating therapy has given us very, very good results. And so the method that we're using to create this personalized anti-tumor task force is based on dendritic cells. Dendritic cells are called presenter cells. They're very important in the immune system, and they actually present the foe to the specific area of the immune system designed to attack that. So if you have an infection, the dendritic cells are going to go and call on the cells that fight bacteria, or on the cells that fight viruses, or on the cells that fight fungus.
So
Very
there's
specifically.
specific white cells for different
Yes.
diseases, different bacteria,
Yes.
different viruses. So if they have a cold, it's
Even if you hit your thumb with a hammer,
okay.
the dendritic cells are going to present.
So the dendritic cells go and say, "Hey, that's the issue. You wipe
Go
left
and
out,
attack.
go and attack."
If there is no presentation, nothing happens.
Okay.
And tumors arise, as we've been talking, from normal cells.
Mhm.
Normal cells that are mutated. And it takes sometimes the whole life of the patient, where the Dendritic cells will not recognize that as a foe because it began from a normal cell.
So your own body doesn't know you even have cancer.
Exactly.
Okay.
Your own dendritic cells.
So don't-
The body knows, but the dendritic cell doesn't and will not activate the killer cells.
Okay, that makes sense.
And so in order for that to happen, antigens have to be the elements that activate the dendritic cells. So the dendritic cell vaccine consists of activating your dendritic cells with a specific antigen of your tumor so that the dendritic cells drop their,
Mhm. So they could recognize
how
it.
do you call the
veil.
The veil.
The veil.
You
From
take
your
out
eyes.
these guys. Like,
Right.
from-
And now the immune system says, oh my God, there's this guy and I have these special forces to attack it. And so that is what a dendritic cell is. And Dr. Larraga was talking about the lymph nodes and how big of a role they play in the immune reaction. Well, the killer cells are within the lymph nodes.
Okay.
Some other areas as well.
The NK and the lymphocytes, right?
The specific T cells or white cells that are created to fight cancer are called natural killer cells or NKs. And so our dendritic cell vaccine addresses that. Now, this is a very sophisticated and complicated procedure that is done at a very specialized laboratory, which we have here at the Oasis, by very specialized personnel. So it's not something that's easy to do and that anybody can do. And these guys at the laboratory are always looking for ways of making that more effective. So there are ways to make this system a little bit more effective. One of them, for instance, is that we can obtain dendritic cells from the blood, but we can also obtain killer cells from the blood. And we make the presentation of the killer cells in the lab. And so we can then inject this presented T cells, killer cells, to the patient's body, and those cells need no presentation.
Okay,
And so those will immediately go and attack.
so they need to recognize because they're new. They're new.
They
and
already, we presented them with the antigen
Okay,
of the
okay,
tumor,
got it. And they know where to attack.
and they know where to attack.
Like a guiding missile.
Right.
Okay.
They need no presentation. And we use this as a bridge because at the same time or the next day we apply the dendritic cells that have been activated with that antigen. And those will start, presenting the antigen to other T cells or NK cells.
So the NK cells first, they attack, then the dendritic cells come in and they start signaling to all the other
To the
white blood
rest.
cells to
Right.
attack the tumor.
Yes. That's another variation is where we actually obtain only antigens from tumor tissue. This can be fresh tumor tissue or paraffin block or dead tissue that was used to diagnose your cancer by the pathologist.
So you can biopsy a portion of the tumor, either back home or here at Oasis, or you can have the paraffin blocks from your oncologist when
Yes.
they actually do
And you
tumor
can
extraction.
bring those and
Yeah.
we can obtain antigens from that. So the big advantage is that it's much easier to obtain antigens from tumor tissue than from
circulating
circulating cells.
Mhm.
But not only that, we can use the antigens directly as a vaccine to activate all of our dendritic cells, which are in the billions. Okay. There's another thing that is a lot more complicated, but we're also doing is called the TILs. TILs are tumor infiltrating lymphocytes, and these are the NKs, the natural killer cells that were able to break all of the barriers that the tumor has to protect itself, and they actually got into the tumor and they infiltrated the tumor. So for you to more or less make a picture of that, the natural killer cells are your normal soldiers, and the TILs are the Rambos,
The Rambos, the Delta Force,
the special
the
forces.
special forces.
And so we can then clone, and the correct term is culture, but for everybody to understand, we clone them from, let's say, 100,000 to millions, 40, 50 million of those cells. And then we inject those cells back into the patient. And so we're working on all of these variations of this very personalized vaccine for our patients. And since we started doing that about 12 years ago, our results have significantly improved because we have been able to use the patient's immune system as a source of a resource.
Help
to
the
fight
immune
the
system
cancer.
fight the cancer. You
Correct.
add elements like ozone, oxygenation, hypothermia, infrared, laetro, vitamin C, EBU, and everything for the metabolic effect.
For the metabolic part.
Then you personalize a vaccine to attack the tumor from the actual tumor cells, so they can know what to attack. I got it. I got it. That is. I hope you guys understood that. I hope you guys understood that.
And I think that for breast cancer is a big step because nobody was looking for cell therapy in breast cancer because breast cancer had it all, like surgery, chemotherapy, targeted therapy, hormonal blockers, PARP inhibitors. So nobody was like even considering breast cancer for example, dendritic cell therapy.
Correct.
We were looking into lung cancer, melanoma, like aggressive cancers that we didn't have a choice. But now, including like, yes, you have all these options, but also we can boost your immune system. So you can also, besides having all these metabolic therapies, also have the immune system. I think that is a big step for breast cancer diagnosis.
Yes.
And we appreciate that. We appreciate that.
Yeah.
I think, wow, it's almost been an hour. Okay. We're gonna do one more question, and then we're gonna let Dr. Contreras give us. Let me see if I can share the screen later on. And do you want to do the?
Yeah, I can show a couple of cases.
Okay.
These were cases that we presented 2 weeks ago. We have newer cases, but we were so busy yesterday and today that I forgot to tell Dr. Larraga to bring fresh new cases, which we have now.
We have, okay, so we'll do one more question, then we'll do the before, the kind of like a before and after of the treatments, and then we'll sign off. But I want to thank you again for attending. This is going to be up on our Facebook page and our YouTube page tomorrow. So if just in case you missed it, because we had over 3,000 people register. So great. This is a great question from Australia, Sharon Lyon. Why aren't oncologists trained in alternative medicine that doesn't kill you? That's the question.
It's a very good question, and there's no easy answer for that. But I can tell you that younger oncologists are a lot more open to alternatives than olders like me. But the reason for that is that the amount of information on alternatives is very scant clinically. So there's hundreds of publications on the effect, anti-tumor effect of nutrients in cancers on the Petri dish, and sometimes in animals. It will never get to clinical trials. Why? There's no conspiracy against them. What happens is that you have to prove to the government here or in Australia or in Mexico that your drug is safe and effective. Effectiveness is very easy to prove, right? The tumor is this big and now it's so. But is it safe? One of the questions was, do we kill more patients with treatment or not? Well, we have a lot of cured patients that died because of the therapy. So they're not safe. And safety is a very complicated thing to prove and very costly. And the only way to make back your money in America, the average is about $800 million.
For a drug.
For one drug.
For one drug.
For one purpose.
One purpose.
Okay.
Through the FDA, yeah.
To get it through the FDA. And most of that money is spent on safety issues. And so the companies will make their money back because the government will offer them a patent with a monopoly of their invention for 20 years. Which sounds correct, right?
Yeah.
You need to make your money back.
Yes.
Now, there are no patents for natural.
Okay.
And you still would have to spend the $800 million to prove safety. And they would give you, if you prove that it's safe and effective, they would give you
But would they give you a patent for vitamin C?
They will not give you a patent.
For vitamin K?
So that happened to my father with amygdalin. He was able to get it approved here in Mexico. in the 70s, and it was, I think, $375,000. The day that it was approved, 7 other laboratories started. You see,
Yeah.
and so in fact, we stopped producing it because the other guys were more effective than us, and we started buying from them. And my father never made that money back.
In Mexico, I mean, is it more of a, if it's approved in other countries, you can use it clinically here?
No, and you still have to.
Register it,
It's
right?
much easier. Okay, let's say that it's already approved in the States or in Europe.
Mhm.
Usually, it's only paperwork,
Got it.
but
got
you
it.
have to get it. You have to get it registered.
Exactly.
And when you go from scratch, let's say in America, it would be $800 million. Here in Mexico, it would be about 10 million.
Yeah.
But then the market is very limited in
Exactly.
comparison to America. So no, you cannot just import them.
Okay.
You have to go through a process.
Perfect.
So very good question. So let me show you a couple of cases from the beginning of the month.
Okay, 1 second. Okay, let me get this going.
So they're still fresh enough, 2 weeks old or so.
1 quick second. Let me share.
Go directly to the.
Let me share first.
Oh, okay.
Just a quick question. Can you
Let's
see
do this
this?
Oh,
in
yeah.
the chat option, can you just tell me if you can see this, yes or no? Anybody?
So we don't know if they're watching
Yeah,
this?
Yes.
yeah, we're
Oh,
good.
yes, okay.
And
Thank you for
Yvette,
answering.
Thank you.
Yvette says these webinars are great. Thanks for all the information. We appreciate it. Okay,
So let me show you a couple of cases.
you want to press here? So it will.
This one, right?
Yeah. Perfect.
Okay, so can't
Why
see
don't,
that.
yeah, why don't we, just give me a second.
Too much technology
Too
for
much
a
technology.
Mexican doctor. Okay, so this is a patient that came to us, the date is here, July the 21st of 2022. And this is what's called a PET scan. Remember that I told you that the tumors light up. So everything that is black, almost everything that is black is tumor activity. All of this is tumor activity. The brain uses a lot of sugar, and that's why it lights up. The kidneys excrete the contrast material, and they light up, but it's not cancer. And then the contrast material will go to the bladder. The rest, all of this is cancer. He came with a very, very large tumor here that was ulcerated, very, very poor quality of life. So I decided to remove this tumor. And now, how do I look at the date here, Augusto?
Oh, yeah. there you go.
Okay. So she came back November 29th of 2022, just a few months later, right? 4 months later, and look at the improvement. So when somebody asks, most of them are in the lung, but there's a lot of tumors also in the bones. And this patient is still alive and doing very, very well. So let's go to another case. And this is a breast cancer patient that had all the therapies that you can imagine. Okay, well, a good number of chemotherapy protocols, hormone therapy, everything, and every therapy failed her, and she was sent home to die. And so she's doing great.
She had massive
Look
activity.
at this one. So this is a patient whereas in the other patient, most of the tumors were in the lung. These are all the bones. Look at that. All of the bones are involved with this tumor. And so let's look at the dates. May the 2nd, right?
Yes.
2022. And then by August 15 of 2022, virtually all the tumors were gone.
3 months.
So there was a question there that if you have bone metastases, can they go away? Well, now you're looking at a very specific case.
Not a real case. Perfect, perfect. All right, let's see. Here's now. I can so stop sharing. We need monitor. Okay, guys, I want to thank you all from the bottom of our hearts, from the Oasis family. Thank you for joining our webinar today. It was a great webinar, great questions, great information. And we'll have this up on our YouTube page and Facebook tomorrow. Some snippets in TikTok and Instagram is the new way of how we got to do things now. And I want to thank Dr. Paulina Larraga for joining.
Thank you very
us
much.
Thank you for
on this
inviting me.
Breast Cancer
Pleasure.
Awareness Month. We're going to ask her to join us more often. We have these webinars every 2 weeks, and we kind of always change the topic. And I think the next 2 weeks is going to be more about holistic medicine and stage 4 cancer Q&A. But we'll send the invites to everybody so they can be aware of what's going on. Please pass the word along. Once again, thank you so much. If you have any questions, want to speak to one of our doctors, want to speak to Dr. Contreras, Dr. Paulina Larraga, give us a call or fill out one of our contact forms on our website. We'll be happy to help you. And we want to thank you again. And have an amazing day, amazing night, an amazing afternoon. From Tijuana to the world. Thank you for everybody.
God bless.
Thank you.